My father-in-law was 71 years old, retired teacher, walked every morning, took his blood pressure medication like clockwork. Not a man who cut corners with his health. His wife woke up at 5:30 one morning and noticed he was breathing strangely. By the time the ambulance arrived, he had already had a massive stroke. He survived, but he spent the next 2 years relearning how to speak. When I reviewed everything with his care team afterward, something struck me. Not the things he was doing wrong. The things nobody had ever told him. Things about what happens to your cardiovascular system between midnight and 6 in the morning. Things about the hours when most strokes and heart attacks actually happen. Things your 15-minute appointment simply does not cover. Today I want to walk you through 7 nighttime habits that the research shows are quietly increasing cardiovascular risk in seniors while they sleep. Not sensational theories. Not conspiracy narratives. Just the clinical evidence, explained plainly, with practical changes you can start making tonight. Some of these will surprise you. One of them involves the position you sleep in every night. Another involves a medication timing question your doctor may never have raised with you, even though a study of 19,000 patients has a very clear answer. And one involves something sitting in your medicine cabinet right now that the research says should not be taken within 4 hours of sleep if you are over 65. I am not here to frighten you. I am here to give you information that can make a real difference. 7 habits. Let us start at number 7. Welcome to Better Health Seniors. Before we get into the habits, I want to spend 2 minutes on something foundational. Because once you understand this, every habit on this list will make immediate sense. Your cardiovascular system does not work at a constant level around the clock. It follows a circadian rhythm, a 24-hour biological cycle that governs blood pressure, heart rate, hormone levels, and blood clotting activity. During normal sleep, blood pressure drops by about 10 to 20%. Cardiologists call this nocturnal dipping, and it is protective. It gives your heart and arteries a genuine recovery window. People who show healthy nocturnal dipping have significantly better long-term cardiovascular outcomes than those who do not. But in the early morning hours, typically between 3 and 6 in the morning, something changes. Your body begins preparing for waking. Cortisol and other stress hormones start rising. Your heart rate increases. Your blood pressure climbs back up. This early morning blood pressure surge is well documented in the literature, and it is the window when strokes and heart attacks are most likely to occur. The American Heart Association 2024 statistics report confirms that cardiovascular events cluster in the early morning hours in a pattern that is directly linked to this biological surge. This is not random. It is physiological. For people with healthy cardiovascular systems, this surge is manageable. For people over 65 with hypertension, arterial stiffness, or existing coronary artery disease, this same surge can rupture a plaque, dislodge a clot, or overwhelm a heart that is already working near its limit. What the habits I am about to cover have in common is this. Each one, in its own specific way, makes that early morning cardiovascular window more dangerous. And conversely, addressing each one makes it safer. Let us go through them. Habit number 7 is something most seniors do every single evening without thinking about it. Sitting for extended periods in one position between dinner and bedtime. Picture a typical evening. Dinner is done by 6:30. You settle into your favorite chair or sofa to watch the news, a show, maybe a game. You sit there for 3, 4, sometimes 5 hours before going to bed. It feels like rest. And after a long day, it is earned rest. But here is what is happening in your legs during those hours. When you remain motionless in a seated position for extended periods, blood flow in your lower extremities slows significantly. Your leg muscles normally act as a pump, contracting as you move and helping push blood back toward your heart. When you stop moving, that pumping action stops too. This creates what is called venous stasis, a pooling of blood in the deep veins of your legs. And pooled, slow-moving blood is more prone to clot formation. Small platelet aggregates can form. In healthy young people, these typically dissolve before they cause any problem. But in older adults, particularly those with reduced circulation, diabetes, or atrial fibrillation, these small clots can persist and grow. Research from the American Heart Association analyzing more than 8,000 adults over age 45 found that uninterrupted sitting time, specifically sitting for long stretches without breaks, was significantly associated with cardiovascular event risk. The key finding was that it was not total daily sitting time that mattered most. It was the uninterrupted stretches. 4 hours of sitting without standing was measurably more dangerous than 6 hours of sitting with regular movement breaks. And here is the specific overnight risk. When you finally stand up to go to bed after hours of sitting, changes in body position shift blood pressure and can dislodge small clots that formed during the sitting period. The early morning hours, when you wake and your blood pressure surges, is a vulnerable window for any clot that made it into circulation during the night. What to do? Set a reminder on your phone for every 30 minutes during your evening sitting time. When it goes off, stand up. Walk to the kitchen and back. Do a slow lap around the living room. You do not need to exercise vigorously. You need to restore blood flow in your legs. 60 seconds of movement every 30 minutes is enough to interrupt venous stasis. That is 60 seconds to meaningfully reduce an overnight cardiovascular risk you probably did not know you had. If standing is difficult for you, ankle circles and calf pumps while seated accomplish a similar goal. Contract your calf muscles repeatedly for 30 seconds. That activates the same venous pump mechanism as walking. Habit number 6 is one of the most common and least discussed contributors to overnight blood pressure problems in seniors. Eating high-sodium meals in the hours before sleep. Here is the physiology. When you eat a high-sodium meal, your body retains water to dilute that sodium. More fluid in your bloodstream means higher blood pressure. This sodium-driven blood pressure increase typically develops within 1 to 2 hours of eating and can add 15 to 25 points to your blood pressure reading. During the day, when you are upright and active, your kidneys process sodium reasonably efficiently. But here is what changes after 65. Research consistently shows that kidney function declines with age, and the ability to excrete sodium overnight slows significantly. Sodium you consumed at 7 in the evening may still be influencing your blood pressure at 3 in the morning, exactly when your cortisol surge is also pushing blood pressure higher. You are layering two blood pressure elevating forces on top of each other during the most vulnerable cardiovascular window of the night. A study published in the Journal of the American Heart Association tracked adults over 60 with hypertension and measured their 24-hour blood pressure in relation to dietary sodium timing. Participants who consumed high-sodium meals close to bedtime showed significantly elevated nocturnal blood pressure compared to those who consumed the same total daily sodium earlier in the day. The critical variable was not how much sodium they ate. It was when. The trap that catches most people is processed food. 77% of dietary sodium in the American diet comes from processed and restaurant food, not from the salt shaker. A typical frozen dinner labeled as heart-healthy can contain 900 to 1,200 milligrams of sodium. Canned soups average 1,000 to 1,500 milligrams per can. Deli meat sandwiches easily reach 1,500 milligrams. Most people have no idea what they are actually consuming because the sodium content is not prominently displayed the way calories are. What to do? Aim to finish your highest sodium meals before 5 in the afternoon when your kidneys are most efficient at processing it. For evening meals, focus on fresh proteins like grilled fish or chicken, non-starchy vegetables prepared without added salt, and whole foods you prepare yourself where you control the sodium content. When buying packaged foods, look at the actual milligram count, not the marketing language on the front. Anything over 600 milligrams per serving eaten close to bedtime deserves a second thought. Habit number 5 affects the physical properties of your blood while you sleep, and most seniors are doing this without realizing it. Here is the situation. Many older adults deliberately reduce their fluid intake in the evening to avoid waking up multiple times at night to use the bathroom. This is completely understandable. Disrupted sleep is frustrating, and nocturia, nighttime urination, is genuinely disruptive to quality of life. But the cardiovascular consequence of going to bed dehydrated is specific and significant. Your blood is approximately 92% water. When you are dehydrated, blood viscosity increases. Thicker blood flows more slowly. It is more prone to clot formation. The platelets that would normally pass through narrow arterial spaces begin to aggregate more easily. A landmark study published in the American Journal of Epidemiology followed over 20,000 adults and found that bedtime hydration status was significantly associated with fatal coronary heart disease risk overnight. Adults who went to bed well hydrated showed meaningfully lower rates of early morning cardiovascular events. The mechanism is direct. Hydrated blood flows more easily through narrowed arteries during the early morning blood pressure surge. Dehydrated blood, thicker and stickier, is far more likely to form the clot that causes a heart attack or stroke during that same window. There is also an age-specific factor here. After 65, your sense of thirst decreases by roughly 40%. This means you can be significantly dehydrated without feeling thirsty. Research in the Journal of the American Geriatric Society found that the majority of older adults admitted to hospitals for various conditions were dehydrated on admission, even though most reported drinking what they considered adequate amounts. What to do? The solution is not to drink large amounts of water right before bed. That will indeed cause nighttime awakenings. The solution is to front-load your hydration earlier in the day. Target roughly 64 ounces of fluid before 5 in the afternoon. Then, about 90 minutes before your target bedtime, have 4 to 6 ounces of water. This is early enough to allow one bathroom trip before sleep while providing meaningful overnight hydration. Check your morning urine color as a simple hydration indicator. Pale yellow means well hydrated. Dark yellow means you went to bed dehydrated and your cardiovascular system was working under increased strain all night. Habit number 4 involves a combination that a significant number of seniors engage in regularly without understanding the specific cardiovascular risk. Here is how this typically looks. A glass of wine with dinner, or perhaps a nightcap at 9 in the evening to help unwind. Then a sleep aid at 10, either a prescription medication like zolpidem or an over-the-counter option containing diphenhydramine, the active ingredient in most PM pain relievers and antihistamine-based sleep aids. Each of these substances has its own effect on your cardiovascular system. Alcohol initially lowers blood pressure and heart rate, which feels relaxing. But 4 to 6 hours after consumption, your nervous system rebounds. Blood pressure spikes. Heart rate increases. This rebound effect from alcohol consumed at 9 in the evening lands in your bloodstream at 1 to 3 in the morning, exactly during the overnight cardiovascular window. Sleep medications of several types suppress the central nervous system and reduce heart rate variability, meaning your heart becomes less responsive to signals that regulate its rhythm. In a normal sleep state, your brain continuously monitors and adjusts heart rhythm. Certain sleep medications dull this monitoring function. When alcohol rebound and sleep medication-induced cardiac monitoring suppression occur simultaneously in the early morning hours, the combination creates a window of elevated arrhythmia risk that neither substance creates alone. A study published in the European Journal of Preventive Cardiology followed over 4,900 adults over age 60 who used prescription sleep medications. The group that combined sleep medication with regular evening alcohol consumption showed significantly higher cardiovascular mortality compared to those who used neither or either alone. The increased risk was not linear. It was multiplicative. The combination was meaningfully more dangerous than either factor independently. What to do? If you take any sleep medication, do not combine it with alcohol on the same evening. The risk is real and specific. If you regularly use both, this is a conversation worth having with your physician, not because either is inherently catastrophic in isolation, but because their cardiovascular interaction in the early morning hours is documented and avoidable. For sleep without medication, the research supports consistent sleep scheduling, a cool dark room, and avoiding screens for 60 minutes before bed. These interventions have meaningful evidence behind them and carry no cardiovascular risk. Habit number 3 is the one that prompted the title of this video, and I want to be careful to present it accurately because the research here is more nuanced than most content suggests. There is genuine clinical interest in the relationship between sleeping position and cardiovascular health. The American Heart Association published a dedicated scientific statement in 2024 on the role of optimal sleep in brain and heart health, which acknowledges that sleep position may influence cardiovascular outcomes in specific populations. Here is what the research actually shows and what it does not show. For people with obstructive sleep apnea, sleeping on your back significantly worsens apnea severity. And obstructive sleep apnea is directly linked to higher rates of hypertension, arrhythmia, stroke, and coronary artery disease. The AHA has documented this connection clearly. A clinical trial published in Sleep Medicine found that avoiding the back sleeping position meaningfully reduced apnea severity in people who had experienced strokes. For this group, position matters significantly. For people with heart failure, cardiologists at Emory Women's Heart Center note that some patients find right side sleeping uncomfortable, and that left side sleeping may reduce gravitational strain on the heart in people with certain structural conditions. For stomach sleepers, there is consistent concern about neck rotation. Chronic neck rotation greater than 45 degrees during sleep can compress blood vessels supplying the brain. Neurovascular specialists have noted this as a contributing factor in some stroke cases, particularly when combined with existing arterial compromise. What does this mean practically? If you have been diagnosed with obstructive sleep apnea, sleeping on your side rather than your back is the single most accessible intervention you have, and it is directly supported by the research. Left side or right side are both meaningfully better than back sleeping for apnea severity. If you have heart failure, talk to your cardiologist about position. They will have specific guidance based on your echocardiogram and clinical picture. If you sleep on your stomach with your neck significantly rotated and you experience morning headaches, morning dizziness, or visual changes on waking, mention your sleeping position to your physician. It may be relevant. For people without these specific conditions, the research does not currently support a universal recommendation about left versus right side sleeping. What it strongly supports is avoiding chronic stomach sleeping and, if you have sleep apnea, avoiding back sleeping. These are the evidence-based positions. Habit number 2 is one of the most practically important items on this list because it involves something sitting in the medicine cabinets of millions of American seniors right now. Diphenhydramine. This is the active ingredient in Benadryl, most PM pain relievers like Advil PM and Tylenol PM, and the majority of over-the-counter sleep aids sold under brand names like Unisom Sleep Tabs. It is inexpensive, available without a prescription, and widely used by seniors specifically for nighttime sleep. Diphenhydramine is a first-generation antihistamine with what pharmacologists call strong anticholinergic properties. Anticholinergic means it blocks acetylcholine, a neurotransmitter that plays a key role in regulating heart rate, heart rhythm, and the electrical conduction system of your heart. A landmark study published in the BMJ in 2023 analyzed 317,446 adults over age 65 who were hospitalized for acute cardiovascular events, including myocardial infarction, stroke, arrhythmia, conduction disorders, and cardiovascular death. The researchers measured anticholinergic drug burden in the 30 days before each event. The conclusion was direct. Recently raised anticholinergic burden was significantly associated with increased risk of acute cardiovascular events in older adults. A separate large population study from Stockholm published in BMC Medicine followed 508,273 adults over 13 years and found that cumulative anticholinergic drug exposure was independently associated with incident cardiovascular events, with the association strongest in older adults. Here is the specific overnight mechanism. Diphenhydramine suppresses the autonomic nervous system's regulation of heart rhythm. During the day, if your heart rate fluctuates or a rhythm irregularity begins, your conscious nervous system has compensatory mechanisms available. At night, during deep sleep, those mechanisms are less active. Your heart is more reliant on its automatic regulatory systems. When those systems are pharmacologically suppressed by a medication you took before bed, the margin for error narrows during the early morning cardiovascular surge. It is important to say clearly that diphenhydramine is not acutely dangerous in a single dose for most people. The research concern is about regular use, specifically nightly use over weeks and months in older adults with existing cardiovascular conditions or risk factors. The FDA explicitly states that diphenhydramine-based sleep aids are not intended for chronic use, but the labeling does not communicate this warning prominently. What to do? If you are using a PM medication or Benadryl-type sleep aid more than 2 or 3 nights per week, talk to your physician about alternatives. Low-dose melatonin, specifically 0.5 to 1 milligram taken 90 minutes before bed, has meaningful evidence for improving sleep onset with no documented cardiac risk. Magnesium glycinate at 200 to 400 milligrams in the evening has evidence for improving sleep quality. And sleep hygiene improvements, consistent bedtime, cool room temperature, no screens for 60 minutes before sleep, have research support comparable to medication for mild insomnia in older adults, with 0 side effects. If you are taking a prescription medication with anticholinergic properties, including some antidepressants, certain bladder medications, and some antihistamines, ask your physician to review your complete medication list using the Anticholinergic Cognitive Burden Scale. This is a validated tool used in geriatric medicine specifically to evaluate cumulative anticholinergic drug burden in older adults. Your pharmacist can also run this review. It takes about 5 minutes and could be genuinely important. Habit number 1 is the one that I find most remarkable from an evidence standpoint, because the research is large, rigorous, and the practical implication is simple. Yet it remains one of the most underutilized insights in cardiovascular care for seniors. If you take blood pressure medication, and roughly 3/4 of Americans over 65 do, you are almost certainly taking it in the morning. That is what the prescription label says. That is what your physician told you. That is the default in clinical practice. But there is a specific clinical problem with morning dosing for many patients. Most oral blood pressure medications have a duration of action of roughly 12 to 16 hours. A medication taken at 8 in the morning is at its lowest blood concentration by midnight to 2 in the morning, exactly when your body enters the early morning blood pressure surge. In other words, you are most vulnerable to hypertensive events during the window when your medication has worn off the most. The Hygia Chronotherapy Trial, published in the European Heart Journal, addressed this question directly. This was a prospective, randomized trial involving 19,084 patients with hypertension followed for a median of 6.3 years. Participants were randomized to take their blood pressure medications upon waking versus at bedtime. Same drugs, same doses, only the timing changed. The bedtime dosing group showed significantly better control of overnight blood pressure, specifically asleep blood pressure, which the research identifies as the most important predictor of cardiovascular risk. The hazard ratio for the primary composite outcome, which included heart attack, coronary revascularization, heart failure, stroke, and cardiovascular death, was substantially lower in the bedtime group. It is important to present this with appropriate nuance. A subsequent large UK trial called the TIME study, published in The Lancet in 2022, examined the same question with a different methodology and found that timing of medication did not independently influence cardiovascular outcomes when controlled for other variables. The scientific community is actively debating these findings. This is not a settled question where every physician has consensus guidance. What is settled is this. For patients who are non-dippers, meaning people whose blood pressure does not drop normally during sleep, which is common in older adults and in people with diabetes or kidney disease, the overnight blood pressure window is specifically high risk. And 24-hour ambulatory blood pressure monitoring, which many cardiologists consider the most important blood pressure measurement available, specifically captures this overnight window. What to do? Bring this question to your next physician appointment. Ask specifically whether your blood pressure is adequately controlled during the overnight hours. If you have never had ambulatory blood pressure monitoring, a 24-hour wearable monitor that records your blood pressure every 20 to 30 minutes, including during sleep, ask whether it would be appropriate for your situation. If your overnight readings show inadequate control, bedtime dosing of at least one of your medications is a conversation worth having with your prescribing physician based on the specific clinical evidence. Do not change your medication timing on your own. Some medications have specific reasons for morning dosing related to their pharmacology or your other conditions. This is a physician conversation, not a self-directed change. But it is a conversation the research says is worth having. Let me bring these 7 habits together into a practical picture, because what I want you to see is how they interact. The early morning hours between 3 and 6 are when your cardiovascular system faces its highest daily stress. Blood pressure surges. Cortisol rises. Clotting tendency increases slightly. This is physiologically normal. But it becomes dangerous when multiple risk factors are stacked on top of it simultaneously. You sat for 4 hours without moving during the evening, so small clots formed in your legs. You ate a high-sodium dinner, so your blood pressure entered the night already elevated. You went to bed mildly dehydrated, so your blood is slightly thicker than it should be. You took a diphenhydramine sleep aid, so your heart's regulatory mechanisms are partially suppressed. Your blood pressure medication wore off at midnight, so you are unprotected during the surge. And you are sleeping on your back, which is worsening your undiagnosed sleep apnea, driving your oxygen levels down and your blood pressure up. None of these factors alone would necessarily cause an event, but stacked together, they create a cardiovascular environment that is genuinely dangerous in a body that is already managing arterial stiffness, reduced kidney function, and compromised insulin sensitivity that comes with age. Now reverse the picture. You stood up every 30 minutes during the evening, so blood flow remained healthy in your legs. Your dinner was a fresh piece of fish and roasted vegetables prepared at home with minimal sodium. You drank adequate water through the day and had a small glass 90 minutes before bed. You took no diphenhydramine. You had a conversation with your cardiologist about overnight blood pressure, and your medications are timed appropriately. You sleep on your side. These are not difficult interventions. They are not expensive. They do not require surgery or new diagnoses. They require knowledge, and they require taking the right questions to the right appointments. I want to be clear about a few things before you act on anything in this video. Do not change your medication timing without speaking to your physician first. This is not a general caution disclaimer. It is clinically specific. Some medications have pharmacological reasons for morning dosing. Some combinations require morning timing to avoid interactions. Your physician needs to evaluate your specific medication list, your specific diagnoses, and your specific cardiovascular risk profile before recommending any change in timing. The research I have cited today is real and peer-reviewed, but research on populations describes risk and association. Your individual situation may have factors that change the calculus. Bring these studies to your appointments. Ask the specific questions. That is how you use this information safely. If you have symptoms that concern you, chest tightness, palpitations, morning dizziness, unusual fatigue, shortness of breath at night, do not treat those with lifestyle changes alone. Those are symptoms that warrant evaluation. The habits we discussed today are preventive measures for people who have been assessed and cleared for home health optimization, not replacements for medical evaluation of active symptoms. And one last practical point. If you have not had a 24-hour ambulatory blood pressure monitoring study, ask your cardiologist or primary care physician whether it is appropriate for you. The overnight blood pressure reading it captures is the most predictive measurement available for cardiovascular risk. Many patients have well-controlled daytime blood pressure, but significantly elevated overnight pressure that nobody has ever measured. That overnight reading, or the absence of the normal overnight dip, is one of the strongest independent predictors of adverse cardiovascular events in the literature. My father-in-law is 77 now. He still walks every morning. He still takes his medications. But his physician added ambulatory blood pressure monitoring after his stroke, and they found that his overnight blood pressure was not adequately controlled despite acceptable daytime readings. His medication timing was adjusted. He now uses a wedge pillow because he was found to have mild sleep apnea. He no longer uses diphenhydramine for the occasional sleepless night. These were not dramatic interventions. They were practical adjustments based on evidence that was available but had never been connected to his situation until someone took the time to look. That is what I hope this video does for you. Not alarm you. Inform you. Give you the specific questions to take to your next appointment. Point you toward the research that supports a conversation your 15-minute visit may not have reached. Drop a comment and tell me which of these 7 habits you were not aware of before watching this. Or tell me which one you are going to raise with your physician at your next visit. I read every comment and I respond to as many as I can. If this kind of evidence-based, practical content serves you, subscribe to Better Health Seniors. Every video on this channel is built on current peer-reviewed research, written in plain language, for people your age who want accurate information about what the science actually says. I will see you in the next video.